Hello, today we are going to be discussing endodontic lateral condensation. The endodontic materials that you see on the screen are Gutta Percha points, accessory Gutta Percha points, files, paper points that we will be discussing during this lecture. But briefly, I would like to go over the pulp biology and dentin, enamel, and the pulp itself, and how do they interact with the process of having decay or bacteria enter the pulp chamber. First of all, the pulp biology is that the pulp contains loose fibers, connective tissues with nerves, blood vessels. It has fibroblasts and odontoblasts. The odontoblasts are the cells that actually make the dentin. Depending on the tooth formation, if the coronal part of the tooth is formed, but there is no root associated with the coronal part because it's still in the process of forming, the dentin which is being laid down is called primary dentin. When the root is completely formed and dentin is still being made, it is called secondary dentin. There are also mesenchymal cells in the pulp, which, depending on the amount of trauma or damage that the tooth receives, the mesenchymal cells resort to secondary odontoblasts, and those secondary odontoblasts place what is called tertiary dentin or sclerotic dentin, and that dentin is in response to a major damage to the pulp. Normally, we're talking about an exposure of the pulp. So if you do have a pulp that is traumatized, we're going to be reviewing some of the symptoms and some of the names of the pulp when it is in that condition. Symptomatic apical inflammation is when there is localized pain at the apex of the tooth, and the tooth is sensitive to percussion and palpation. If you are up in this area and you are tapping the tooth and there is an abscess down below, the patient is going to let you know that's sensitive. At the same time, if you press along the bone area here in the vestibule where there is an ongoing infection, the patient also will say affirmative, that is what is being problematic to them. So if that is the condition, it's called symptomatic apical inflammation. It could also be that there is inflammation at the apex of the tooth, but the patient does not experience any discomfort. That normally occurs when the pulp itself has died. It is necrotic. There's a radiolucency, but the patient experiences no pain. Nonetheless, we still need to treat that tooth with the root canal. There is acute apical abscess. This is when you have a patient, they are not happy, they have severe pain, they could have swelling, and normally there is a drainage that needs to happen in order for the patient to be out of pain. But at this point, the exudate, the pus, is still within the bone adjacent to the root of the tooth. Therefore, that pressure is what's causing the patient discomfort. Then there is chronic apical abscess. This is when there has been this trauma to the tooth for such a long time that the abscess has found a way to drain itself. And there's a sinus tract associated with this type of abscess. There is sometimes no swelling, and there doesn't necessarily have to be pain either, but of course there is a problem that there is drainage coming from a tooth because it is in the process of dying. What you need to do when you have a sinus tract drainage is to take an accessory gutta percha point, and you need to insert it where the drainage is coming out, and that gutta percha point will actually go to the apex of which tooth is actually the one in problems, because you may have a drainage in the bicuspid area, but it is actually coming from an anterior tooth, and vice versa. You may have drainage in the molar, but it's coming from a tooth in front, or a drainage in the bicuspid area, but the problem is a molar. So now we are at the point that we know that the tooth needs a root canal. We need to access the tooth. In order to access the tooth properly, there has to be a preparation from the coronal portion that gives you straight access all the way down in the root. There cannot be a curvature or a 45-degree angle, because the instruments that we are introducing into the tooth in order to clean it out, as well as to place the final restoration, need to have a straight access. Therefore, the anterior teeth here in the front need to have a triangular shape. When you come to the cuspid, it becomes an ovoid that is not necessarily a thin ovoid, but enough that you will be able to remove the quite large pulp that cuspids have. When you go into the bicuspid, the upper first bicuspid may or may not have two canals. If it does have two roots, obviously it has two canals. And if it has only one root, it only has one canal. But sometimes you have two canals that actually merge into one. Then you have your second bicuspid. It has an ovoid shape. You have your first upper molar. This is a tricky guy. He may or may not have two mesial canals. It's called mesial 1, mesial 2. And they are normally in a straight line with the palatal canal, and then the distal buccal canal is off to the side. The first and second upper molar have a rhomboid shape for the access. Then we go down to the lower molars, the lower anteriors. I'm getting ahead of myself. And all of these, as you can see, have one canal and more of an ovoid opening. The first and second lower molars have a trapezoid opening access, and normally the distal canal is much larger and easier to find than the mesial. Okay, this slide is a slide that I do want to tell you that there is an apical third, a middle third, and a coronal third of the root, as well as the pulp chamber. And I also want to show that even though we say that we are cleaning out and we are making the internal area of the root conical, you can see that there are some areas that the pulp is wider, that become narrower, and even may have lateral canals. So the idea that everything is going to be circular and symmetrical is not the case. And we will deal with that with sealers and accessory canals that I will be discussing later. The pulpal anatomy follows the contour of the tooth. If you have a very broad, wide, massive root, the pulp is going to be reciprocal to that shape. You may have a very thin narrowing. You also have a thin narrowing of the pulp. And here, just to show you, it may have seemed to you that you have two, and the M1 and the M2 canal, but you see here, it could be that you start off with two, but then they merge into one. So now we are discussing the shaping and the cleaning of the root canal. First of all, we want to make sure that we isolate the tooth properly, and that is a rubber dam, and now we have our files. Files that are placed in the tooth, always, this one does not have a demonstration of it, but they normally have a stopper, a rubber stopper, and there is also an indication of where on the tooth you are going to be using your reference point. The stopper and the reference point, no matter what file goes into the tooth, need to always coincide. So because the first file that you put in, you are going to be determining your working length. And we're going to get into that. But right now, just to discuss what instruments we put into the tooth to clean, they're SS files that have a numbering system. The smallest is 0.6. There is also 0.8. When we start with 10, it goes up in increments of 5. Some may have a 0.2 tapering, meaning that at the tip on up, the taper gets wider by 0.2%. There are H headstrom files, and these cut in a retracting, pulling outward fashion. There are rotary instruments that you put on your slow speed. The gate glidden is one of them. The gates glidden So we're going to be discussing cleaning and shaping of the canals. As you see here, we have a rubber dam, and the rubber dam is to ensure that there is going to be no bacteria or saliva that enters into the tooth. And there is a file, and this file is going all the way to patency. Normally on the file there is a rubber stopper, and the rubber stopper corresponds with an area of the tooth that is a reference point. And that reference point with the stopper will be used with every file, and it is an indication that the file has gone all the way down to working length. We have the H headstroms files, which cut in a retraction, pulling outwards area. Rotary instruments such as the gates glidden and also the wave 1. The gates glidden open up the upper orifice of the chamber in order to get a straight access all the way to the apical foramen. Irrigation medicaments are very important. Sodium hypochlorite is used after each time you go in and you clean out the file. It ensures that there is no sediment that starts at the apex once the file is cleaning out the dentin. You go in there and you irrigate it in order to maintain the patency of the root. There's also EDTA, which is a chelating solution, and it will clean out the dentin and does its purpose for cleaning the inside of the canal. The chloroform is used when we are removing gutta percha. It is not something that you will be doing, but in order for a retreatment, chloroform removes the gutta percha with files. Okay, apical patency. What does that mean? It means that there is an aperture here that is a constriction, And you need to maintain that constriction in order to ensure that the gutta percha or the sealant is not going to go beyond this area. If it does go beyond the root, and it can be an irritant in the bone. So patency means that the smallest file is gone through here probably in 06 or in 08 to make sure that there is no bacteria and there is no pulpal tissue. Patency is reestablished throughout the procedure as the files get larger. There's irrigation, and then a number 6 or a number 8, whatever a file you use to begin with, is pushed through this 8 constriction in order to ensure that there is no blockage. Obviously, we remove the portion of the pulp here that is, if there is any remaining. Okay. The difference between the length of the tooth and working length. The working length is approximately 0.5 to 1 millimeter short of the entire length of the root. The reason for that is what I just described, the constriction. We do not want to have the material go beyond that point. Therefore, if you are the access where the aperture is not necessarily always at the apex of the tooth. In this diagram, you see it's off more to the lateral side of the root. So your working length would be wherever your reference point is, all the way to 0.5 millimeters short of the foramen. Excuse me. Obliterating materials, obturating materials. What type of qualities should it have? It needs to be antimicrobial. It needs to be biocompatible. It needs to have a good flow. It needs to be adhesive in nature, meaning that when you place it into the canal, it actually stays where you place it, dimensionally stable, not affected by moisture, although we are going to limit the amount of moisture that is in the canal. Radio opaque, obviously when you take an x-ray, you want to be able to see where it's present. It has to have good handling qualities, easily removed just in case you need to retreat it, that it doesn't stain, dented, and it's fairly inexpensive as a material. Your endodontic instruments. As you see here, you see a finger spreader. What it does is it condenses the gutta percha off, and this is going to be a lateral spreader. It is going to be placed next to the master cone, and it is going to create space for your accessory cones of gutta percha. Remember, the accessory cones are going to be they're going to be placed laterally, but they're also going to be surrounded in the sealant that you place them in prior to putting them into the canal. Another way of placing the sealer into the canal is by an instrument like this. It's called the Lentino spiral filler. It is a latch. It goes on your slow speed. You place the sealant in this area, so you coat this area, you place it into the canal, and when you turn it on, it's more like a spackle type as it turns. It will put the sealer against all the sides of the root. Endodontic pluggers. Endodontic pluggers have a flat surface, and what they are used for, they are used in 2 areas. Number one, the endodontic pluggers come in various sizes, and they are going to be used when we're discussing vertical condensation. But in this slide, it is telling you that when you heat up the plugger, because at the end of the root canal, you're going to have the master cone sticking out in the coronal portion of the tooth, as well as all the accessory canals, all the accessory points. And what you're going to want to do is heat the plugger, and you're going to have to remove the gutta percha that you are going to be cleaning out the pulpal chamber. Okay? Obliterating materials over the history of time. We see here that we had solids, semi-solids, and paste and sealers. The semi-solids and the pastes are what we are using today. Solids were at one time placed in teeth, and they were silver points. Silver points were placed inside of the canal once it was cleaned with a sealer surrounding the silver points. But they have found that over time, the sealer, it does break down, and there is leaking and corrosion of the silver points once there is moisture that is introduced into the canal, obviously making the root canal seal. It no longer seals the way it should, therefore it needs to be retreated. It's a failure of a seal. Okay, so here we're looking at gutta percha points, but we are not looking at master cones. We are looking at accessory canals, accessory points. And they are not, gutta percha is non-soluble, it is a non-irritant, and you can condense it one next to another. If you take a look here, you will see that there are all different sizes. This is a fine gutta percha point. This is a fine medium, and they go on with the description of being fine, medium, medium large, and you choose which accessory point by the determination of how big the pulpal access is all the way down. If you have a very large opening in the root, you will probably use a larger one. If it's very thin, you will want to use one of the smaller ones. The way of choosing is that these accessory points need to go all the way almost to the working length. It needs to be a little shy because your master cone obviously has sealed where the apical foramen is, but above that there may be some leeway that there could be more gutta percha placed in the area, condensed. So depending on how large that space is how you will be choosing these points. Okay, so here we have the gutta percha, a semi-solid material. It's mostly used in filling root canals. This is a breakdown of what consists inside of a gutta percha. And in this diagram right here, you see that you have paper points and you have your gutta percha. The paper points coincide with the size of your master cone gutta percha. They have the same dimensions. Like I've mentioned in the past, the files, the gutta percha, master cone, and the paper points have all the same dimensions, therefore facilitating ease of use with these materials. Okay, the most popular sealers and why we use them: zinc oxide eugenol, calcium hydroxide sealers, glass ionomer, and resins. The one thing that you have to know about all these materials, although they are used to benefit doing a root canal and helping facilitate, if they have not been set and go beyond the apex of the tooth, they are toxic. So indications. When do you use them? When you need to temporarily fill, meaning not inside of the canal, but you need to temporize a tooth that has a root canal started because either the patient was in pain or there is a delay in the treatment. Calcium hydroxide can be placed in the orifice to make sure that there is no recontamination. If in case the child is young, who is your patient, and they do not have their roots completely developed, only the coronal portion of the tooth is erupting, and say that there is the last 1/3 of the root that needs to be formed, you cannot do a root canal. What you can do is you can pack it with calcium hydroxide and you can wait for the tooth to mature and for the complete development of the root. At that point, a standard root canal can be started. Treatment of resorption. There is internal resorption that may happen in some teeth, and normally the pulpal tissue is removed and it is packed with calcium hydroxide to hopefully to stop the resorption that is damaging the internal portion of the root. There is also management in perforations, and this is something that your dentist will be doing because it is part of the cleaning and the shaping of the root canal. Okay. More indications for the hydroxide sealer. As we discussed, it's apification, which is that there is not closure in the root, and we want to keep the tooth forming the root in order to save the tooth for the patient with normal growth. Apixogenesis is the treatment procedure by which the radicular part of the pulp is contaminated. What we do is we clean that area out and we pack it with an hydroxide sealer, hoping to have apical maturation. And at times, depending on how quickly you access the area, and if not a lot of damage is done, the tooth may or may not need a root canal. Okay, so here we're talking about how we're going to be placing the calcium hydroxide. In this slide, you see that there is a file that they are coating with the sealer. The sealer is you have 2 tubes and it is 1-to-1 ratio consistency. So it's in equal amounts that you mix it and then you have your sealer. I normally do not use a file in order to place the sealer in the prepared tube. What I normally use is the master cone, and I coat it, and I have a pumping motion with the master cone coating all the walls. If for some reason I don't use the master cone, I use the corresponding number of paper points. So it depends what you feel works best in your hands. Okay, so what does the sealer do? The sealer is the filler in between the Gutta Percha and the Gutta Perchas that you are placing in the master cone with the accessory with the accessory cones. Another thing it does is if there is any lateral canals that have been cleaned out, but the Gutta Percha is not going to be expressed laterally, the sealer can also fill those areas. As you read here, it takes care of isthmuses and any irregularities in the root canal. Okay. So placing the sealers, like I mentioned, you can use your master cone, moving it in a pumping direction. You could use a sealer with a file, spinning it in a counterclockwise position. The reason why you do that, just to review, is that you don't want to bind the file into the root. You can use that spiral, the lento spiral, to spackle the sealer against the inside of the canal. You can use a syringe. The syringes, though, is something that you need to be careful of because you never know how much material is going to be expressed in the area. You can also use ultrasonic instrumentation. Okay. As you see, the use of a syringe, as I mentioned, I have not used this because it is difficult to control the amount actually that is expressed into the canal. And they also have ultrasonic instruments. Everything as said before, we try to avoid extrusion of the material past beyond the aperture of the tooth. There are also resins-based that have a primer, sealer, and the cones, and you can use them using lateral or warm vertical compaction. So here we have the areas that are going to determine what you are going to. So here we have the solid core technique, the softened core technique. So with a solid core technique, you have a single cone and you have lateral compaction. And this is when you are using the cold lateral condensation is how I term it, with a sealer. With softened core technique, you have lateral compaction, but it's with warmth. You are actually heating the gutta percha so it kind of blends in one with the other. You also have warm vertical compaction. You have a thermal mechanical compaction and an injected molded gutta percha and a core carrier. So in this slide right here, it says that we have a single cone. I believe it was filled with a core carrier. And what that is that there is gutta percha that is surrounds a very thin piece of plastic. And from the gutta percha, you have your stopper. And what you do is you heat it up in an oven. And once the oven, it heats it to a certain amount, the gutta percha is malleable. Therefore, you put your sealer into the canal, and it is a very straight, continuous application of the single cone all the way to the working length. At that point, what you do is where the orifice of the canal is, you cut it at that point, and there is absolutely no additional accessory cones that are placed inside of the canal. Cold lateral condensation, we reviewed it before, but it involves a master cone. We have either a finger spreader or a regular long handle spreader. You have your accessory cones. The accessory cones do not go all the way to the working length. They are slightly higher than where the working length is, and one is applied over the other, is applied adjacent. You do not, as you see here, you have your master cone against one area of the root, and your accessory cones are just laid on top of it. The accessory cones do not, it's not one on this side, one on the other. It's in one continuous area, and you bring it up. As the root is filled, the accessory cones end up higher and higher. Okay, so lateral condensation step by step. I've already discussed the master cone. Now in the master's cone, what we need is we need to feel a tug back. And the tug back is when the tip of the master cone is embedded in the aperture where we have right above the constriction of the root. And why it should feel like a tug back is because the master cone should fit very snugly in that area. The reason for that is with the sealer that we are going to place around the master cone, we will ensure that it is like a plug. So when we start either by doing vertical or lateral condensation, we know that no material is going to be expressed beyond that point. If by chance you place your master cone and you do not feel that tug back, what could happen is that you could cut approximately 1/2 or 1 millimeter of length at the tip of the master cone, and you can reinsert and see if you get tug back. If you do not get tug back, and if it's still wide, there is also the process that you can go to a higher up file. If you were working with the 30, go to a 35, but it is imperative that the working length be established with that 35. If you put in the 35 and you get tug back, but you're not at the working length, that means you're going to be short in your fill. So you're going to have to go back to the master cone that's below that size and cut it until you achieve the tug back. It is very important to achieve that. There is no getting around it. If you do not get that tug back, you will overfill or extrude material beyond the apical foramen of that tooth. Once you put in your master cone, you must take an x-ray. You have to confirm that you are where you want to be. You coat the walls with the sealer. All of this I have been over with multiple times in the segment. You remove the excess by cutting it with a hot instrument, and it's normally a plugger. Okay, here again is lateral condensation, but it's shown in this series of steps. You see your master cone, you have your reference point, you have your stopper, you have your finger spreader, your accessory that does not go all the way to the tip, but hopefully the sealer is going to go into these lateral canals. As you see, you have your master cone, all the accessories coming, they gradually come up in length because you are filling, this bottom portion has already been filled. If you take a cross section of the tooth, as I said before, they normally are not just conical in shape. They do have more of the anatomy. If you take a look at the root on the outside, it curves out, and so does the internal pulp. Okay, so if you were to take a cross section of the tooth, and we'll start with the upper third, you will notice that you have your master cone, and you will have the accessory cones all the way around it with the sealer material. The sealer material, they call it cement here, needs to be all the way around the Gutta Percha, because the Gutta Percha does not, it shrinks a little bit once you condense it. It has a buoyancy, and what you want, you do not want just Gutta Percha against the root, the dentin there, the cementum. You want it, you want the internal sealer to be sealing this area. If you come to the apical end, you will see that you have your Gutta Percha, master cone, and all the way around it, you have your cement. Warm lateral condensation. Here again, you need to have your spreaders. You need to have spreaders of, like you do of the cold lateral condensation. You have your master cone. You have a heated spreader, and you place your accessory cones against the master cone, and you pack. So this is warm vertical condensation. So you have your master cone. You have achieved working length, and you have removed, this is a lot. You normally remove at least up to a third of the remaining master cone stays in place. But what you do is you take some Gutta Percha, you warm it up, and you pack. And you keep packing warm Gutta Percha upon Gutta Percha that was warm, and as it becomes cool, it becomes one block of Gutta Percha. This is also a different diagram showing you the master cone. Obviously on the sides here, you have areas that can be filled in. You place your plugger into the canal. As you see, it has a rubber stop. You never place any instrument inside the canal without knowing exactly the length that you're going. So here we go. The Gutta Percha is removed, then it's packed, and then you add more Gutta Percha. Okay, so for the final X-ray that we have here, throughout the process of doing the root canal, you will be taking an X-ray when you have your initial file to see if you have gotten to the working length. When you come to the final file, you will take another X-ray to make sure that you are still at your working length. When you put in the master cone Gutta Percha, you will take an X-ray to make sure that you're where you're supposed to be. And then finally, when you're done with the root canal and you have your final fill, you will take a final X-ray. It is important to preserve the tooth at this point to ensure that there is no reinfection. Therefore, when the root canal is done, a final restoration has to be placed. More times than not, it is a crown because the root canal teeth are brittle and they're prone to fracture. But if we take a look also at this root canal, we notice that there is over the orifice a different type of material. And normally we put glass ionomer in this area to seal the orifice. So if in case we need to retreat the tooth and the dentist is going and drilling away the filling and he touches the glass ionomer, then he will know that he is close to the canals. So with the end of this lecture, there are some parting questions that depending on if it's an endodontist that is giving the answer or a general dentist, the question is, what is a successful root canal? Is it if the patient is pain-free and the patient is happy? If the apical lesion that is what made you do the root canal resolves? Is it only when the master cone and all the accessory canals are filled? So your main canal and all the accessory canals are filled, Or is it, if you take the tooth histologically and look at the apex, if there is no inflammation? Or at times we give patients a time frame in which we say that treatment should last. Is 5 years of having a tooth with a root canal, is that success if the patient has it for 5 years? These are really questions that don't specifically have an answer. Of course, we want the patient pain-free. We want lesions to resolve. But at what point can we truly say that we have removed all of the tissue and sealed all of the canals? I don't know. Thank you for listening.